in-person conversation in Ann Arbor, it was a small subset of the group. And so some of these things we do think it's worthwhile repeating at a larger group, but just with some updates and a little bit different of a spin. So again, our intent is not to duplicate, but sometimes we kind of have to. And thanks for bearing with us as we come up with our meeting structure and plan going forward. So here's an exciting one. And I think many are already aware of this, but beginning February 1st of this year, the number of patient surveys has been reduced. So, thank you for your feedback. We had a lot of surveys to start. We eliminated many of them. And this was and if we can go back to the previous slide, this was a painful, tough decision because there's definitely challenges with regards to this because, um, just to go into a little bit more depth on this, that general health questionnaire is the one that is, how much do you exercise? What kind of cardio do you do? What kind of weight bearing do you do? How many times per week? So again, that could be the secret sauce, for our answer for prevention of chronic back pain. So we needed to keep that one. The start back we needed to keep because that's a validated survey, and we actually have a breakout, or sorry, we actually have a pilot with regards to this, and this is one that a model that can predict and stratify patients as to their risk of having chronic back pain, because we can't throw all of our resources in our lowest risk patients who are going to get better on their own and don't want to have all this follow up. But our highest risk patients are the ones that really need all of our resources. So that's where the start back is a benefit. And then some of these PHQ, surveys, it would have been great to monitor depression. It would have been great to monitor if depression improved with any kind of intervention that we've done. But again, these surveys were too many. And so, and back and leg pain were ones that basically just said, how severe is your back pain on a scale of 1 to 10? So again, that'd be kind of nice, but we think a lot of these things wrap into this PROMIS PI. And the PROMIS PI is, as we know, the PROMIS pain interference, which is basically really what we want to get at. How much does this pain interfere with your quality of life? And so many things correlate with this. So we figure the surveys that we've eliminated should correlate well with this PROMIS PI. One of the surveys that we have as well that I've forgotten about, but I believe it's not on the initial, but on the follow-up surveys, is it's a satisfaction question. So, because one of our three goals, patient and clinician satisfaction. Well, we have to be able to measure things that are our goals. So, we'll send out, we've sent out surveys to clinicians, and of course, we don't want to over survey the docs, but we certainly plan on doing that and measuring how satisfied are you in treating patients with chronic back or with acute back pain, but also the patients. So, how satisfied are you with the improvement in your back pain? And so this is something that we'll be able to measure in time because we don't really know what the answers are going to be, but we want to make sure that we're asking the right questions from the start. So at any rate, next slide. So process and pilots. So let's take a look here. So more clinicians at this point, or most clinicians are entering information directly into patient IQ themselves. A fair amount are completing on paper and then passing it off to a team member to enter in. I've tried both. So I've entered a few patients myself. Um, Admittedly, I was kind of nervous. Nobody wants to ask your patients for a favor, so but asking my patients to say, hey, we have these surveys to help us, take better care of our patients with back pain. Is this something you'd be able to help us out with? And different folks have different scripting on that, but so far everybody that I've asked has said yes, and they followed through with at least the initial survey. And so I tried different things. I completed it on, well, actually, I didn't complete it on paper. I had our coordinating center, enter it on my behalf, and probably the most similar thing that we have for this for the larger group is completing it on paper and faxing it to the coordinating center, which is an option. And that worked out well. It was pretty easy. I actually looked back at the questionnaire itself, thinking, okay, well, I know we have a great team, led by Samantha, on the call. She's great, but it's one of those things, trust but verify. Let me look back and see, are the answers they put in what I would have put in, based on how I documented in my note. And, by and large, it was. So the system worked. So it was great. So that showed me that somebody else can enter the information on my behalf, as long as my note is clear. And then I decided that I was going to enter it myself to see, okay, well, do these questions make sense for me? And I did this during the pilot, but I wanted to, since we have some changes, enter the questions myself. Do the questions make sense? How long does it take me? Now, admittedly, the first time I went and did it, it took me a few clicks to figure out where I needed to click. I was trained before, I just couldn't remember, you know. So the first time it took a little bit longer. Once I figured out where to click, the second time it took me less than 4 minutes to enter all the information, which I thought was pretty neat. It was actually pretty quick. So it doesn't really take a whole lot of, a lot of time once you figure out where to click once you get through that first one. From a pilot standpoint, so again, we're offering this fax option, as we discussed, which I think is going to work well and probably going to work for most or for many. And then we also have a pilot where our team is looking into Epic, and this is the one that I tried, at least for groups that have Epic in which we have ability to look at it. So that way, the coordinating center is looking directly into Epic and entering it in Patient IQ for us. So anyway, lots of different options and best practices are going to emerge going forward. So there's a few pilots, and one of them is with regards to the start back, as we've discussed. And with the start back, the as we discussed briefly before, this is one where the patients take a survey at the beginning when they at the first visit, and they're asked questions such as, a patient such as me, should never be active. I shouldn't state these questions because I can't remember them off the top of my head, but it's unsafe for a patient with back pain such as mine to be active, or things like that. And how much do the patients agree or disagree with these questions? And so it's a validated tool that gives us a real good sense of how significant the patient's back pain is going to be over time, or whether it's going to develop into chronic back pain. And so we have a pilot team that's working on this that basically says, okay, so if you take this survey at the beginning and the patient is low risk, you do this. If they're medium risk, you do this. And if they're high risk, based on the start back, you do something else. And basically we want the initial part of the pilot is basically just to test the process. Does the process work? Any process has to be simple, or clinicians and their teams aren't going to do this. And so, is it reasonable to get patients with back pain to take this start back survey from a workflow standpoint before they see the clinician? How do we do that? And then how does the clinician use this tool at the point of care to influence any interventions that they do? So at any rate, that's the first step, and much thanks to the pilot teams that are working on this. We probably should call them out actually verbally. Um, Anybody that's on this in the CC, remember the pilot teams that are working on this?
Yes, it is all of the primary care physicians from Great Lakes, and there is also a couple from IHP. Chelsea would be able to contribute their names. I can't see my screen right now, so
Okay.
except for that.
Or at least the POs, right? To give them credit and thanks for volunteering to help us out
Yes,
with this.
IHP and Great Lakes. So Chelsea, Susan, Kathy, Dr. Podolsky. I'm missing a name, but
Okay, well, thank you so much for your help with this. Again, this could be the secret sauce. This could be a big answer in the future that makes a big difference in patients' lives. Because again, we can't just give everybody more resources, but if we focus resources and say the patients that are the highest risk, a plan for that, and lowest risk, a plan for that, this is something that we theoretically could scale statewide, if it works. So it's kind of exciting to be in at the ground level. Next slide. Defining chronicity. Next slide. Okay, so as key to the project, again, we need to define chronic back pain. And I know we've discussed this at the regional meeting before, but not everybody on this call has heard this. And so there's this concept of the minimal important difference with this PROMIS PI survey. So as a reminder, PROMIS PI is PROMIS Pain Interference, and it's a survey that patient takes at baseline and at various intervals over the next few months. And so basically they say, how much does pain interfere with my quality of life, to just kind of simplify it in very simple words. And the survey has been normalized to define 50 as the general population average overall. And there's a good article. There's actually several articles, but there's one very good one in particular, and we have a breakout group to discuss this in a little bit more depth, that basically says that this minimal important difference is 3, which means if you score, if the average is 50 and somebody scores, 51, well, that's less than 3, so it might not really be significant. If somebody scores 54, well, that's more than 3, so that's a significant difference, versus the average. And so the article actually said somewhere between 2 and 3 was what they came up with. So our proposal was to go with 3, and so the logic is that if 50 is average and 3 is this minimal statistically significant difference, to put it in different words, then anybody that gets to a score less than 53 on this survey, it would be reasonable to assume that they don't have chronic back pain, or that they didn't develop chronic back pain. So next slide. So then we reality checked it against our data. So again, this is the fun, exciting part. This is from Patient IQ. These are all of our patients as of March 15th. So this is an updated slide from what we showed before. And this is patients with what we're going to call usual care. So patients that have seen us and they've done whatever it is that we typically do, because we haven't really done any new intervention yet. We're just measuring patients in their baseline. And as you see, they start off at a 62 from the start, right? And 50 is average, and the minimal important difference is 53. So that's pretty high. And then they get better at 1 month, better at 2 months. And then so by 2 months, most of them really seem to have done well, at least our population as an aggregate. And this is I'm just noticing this today. So seriously, we're at less than 50 at 6 months. That's exciting. So, so this tells me usual care, kind of works, at least for the population at large. So if you go, so this kind of reality checks with our 53, and this is why our proposal was 53 at the 3 month mark, not at the 6 month mark, just because it'll be easier to measure, and we see the data seems fairly flat from 2 to 6 months. And again, over time, we hope to display this graph. I was advised it's too soon to do this, but eventually say, okay, well, patients that had a certain intervention, patients that say that exercise, or patients that were referred for a specific, test or procedure, how do they rank on this graph, versus the baseline patients, and then we'll really be able to see meaningful differences, and then do some trials going forward. So next slide. And again, so we have a breakout group on that. So it's kind of exciting that what we hypothesized really reality checked when we looked at this graph. So what comes next? Next slide. Let's see here. I just want to do a time check. I think I'm still doing okay here. Okay, so this executive committee. So now that we have so much formed as a baseline, going forward, at some point, hopefully later on this year, some clinical data is going to start to come in, and we're going to need to be able to figure out what to do with that data. So how do we analyze the patient IQ data? What type of future QI initiatives are we going to get? So again, if we determine that patients that exercise on a regular basis based on certain parameters have significantly better outcomes, based on this promise PI graph and other things that we review, well, that's an association. It's not a cause and effect. So what are the next steps, to evaluate that? And if we do determine that it really is cause and effect and it's the best practice, well, then how are we going to disseminate that, going forward? So so we need an executive committee to help make some of these clinical decisions. We asked for some nominations, and we appreciate that 4 chiropractors were nominated. We don't have PCPs, although the PCPs within the coordinating center will likely play a significant role in this, and I know I certainly will. And if we look at what the group does, process adjustments. Oh, sorry, let me take a step back. So we have some process adjustments on how we're going to form this executive committee. The initial timeline is going to change, and we are asking for nominations at this point, not just for members of the steering committee, but any QI participants and PO leadership. So if you're participating in the QI and you're motivated, you're interested in MIBAC and helping patients with back pain, we're happy to have you be nominated because we do need PCPs on the committee as well. Bylaws we're working on will likely be very similar to MISIC and MEDIC. And if you're a QI participant or PO leader, look out for an email with a nomination survey within the next few days. Next slide. So the role of the executive committee, again, participate in discussions about collaborative issues, projects, and direction. Seek input from the steering committee, which are basically, previously called our champions, professional colleagues about research. Vote on key decisions for the collaborative, when the data is available, and what to pilot on and what we should be doing, and advise on policies of the collaborative, um, and commitment. So we currently have these 6 steering committee meetings, which are every other month for 45 minutes from 12:15 to 1. This could all change, right? The executive committee itself will decide what works and what doesn't through trial and error with time. But we were thinking to make those steering committee meetings at some point executive committee meetings. So it's a 45-minute meeting every other month. And we'll see if that works, as decisions come out. Plus, of course, attendance at the other meetings that we have for the larger group meetings. Next slide. And the neat thing about the executive committee is this is something that team members can you can put on your application. You can share this. This is something that you can say a statewide initiative, on improving back pain, and you're part of the executive committee. So it's something that could potentially help you with future applications and positions that you have. Plus it's fun. So preliminary details. So we're looking for 4 primary care physicians, and then 1 or 2 will likely be from the MIBAC Coordinating Center. 4 chiropractors. So again, for the primary care, we want diversity, DO and MD. We're certainly open to an APP, advanced practice provider, PA or nurse practitioner. 4 chiropractors spread between some within physician organizations, some who are independent, not within physician organizations. We do need specialists, and over time, their role with this collaborative is going to be determined because we can all take our best guess, but we're not exactly sure what it's going to look like. But clearly, there's importance for urgent care physicians, emergency medicine physicians, PM&R, et cetera. And so having them on the executive committee would be helpful. Definitely physical therapists. The precedent by the other CQIs is that the buyback program director would chair the committee, which is currently me, although we want to make sure that the bylaws don't list specific names because, well, I'm not planning on going anywhere. As we know, anytime you write bylaws, you want them to outlast any specific person if for some reason circumstances change. So we were thinking 2-year terms for most members, but we likely will build into this for a 3-year term for at least 1 PCP and chiropractor to be able to have continuity. So that way we don't have a completely new group of people after 2 years. Although we would, people would be welcome to run for re-election, and I anticipate that they would want to. So more details to come, but we'll send out the details and then ask for voting. And again, certainly looking for more PCPs. Next slide. Meeting updates. Let's see. Time check. I think I'm doing okay here. Okay, so we alluded to this a little bit before that we have the meeting schedule was complex, and we realized that because well, anyways, we have a new meeting format for 2023, and we plan to have a combination of collaborative-wide and regional meetings. And at least at some of these meetings, we plan to have breakouts for the steering committee and then the PO leadership, because there may be some separate topics that each can discuss, and certainly more opportunities for participation. Again, as convenient as virtual meetings are, and I think they work well with a smaller group, you accomplish more, when you're at in-person meetings, and plus they're more fun. So next slide. So, again, when I was looking at our meeting structure before, um, I got confused, right? What's the difference between a collaborative wide, a regional meeting, the steering committee meetings, the PO leaders have meetings, and this is only one collaborative and one tiny piece of everything that everybody does, right? So I was thinking, well, if I got confused, and what's the agenda, for each meeting, and how do we create a balance of, new topics versus trying to ensure that everybody gets the same message. So, we discussed as a coordinating center and agreed it was too complicated. So we wanted to simplify things. But in so doing, we wanted to honor the same dates and times and locations for the meetings that we had set originally, just repurpose them and call them by different titles. And then, of course, we'll come up with a new schedule in 2024, but that's an eternity down the road. So we still have all these meetings. So we had that February 9th meeting in Ann Arbor, which again was a lot of fun. Thanks for everybody for coming and great participation, and for the folks that organized it. I think was Lisa was a big part of that. The virtual meeting, of course, today. And then we have three more meetings. So the May and November one were previously called regional meetings, but we're opening those up to everybody now. And the September was previously called the collaborative wide, and again, also open up to everybody. So there'll likely be, similar focus at each of these meetings. We'll have to see how this goes forward, and then we'll get specifics out to you, as things come up. And so, requirement for delegate. So going back to the left screen, the steering committee meetings, as you see, over time will likely change to the executive committee once it's formed. And you see there the requirements of the delegates of what they need to attend. And then the requirements for POs and QI participants on the March and September meeting are required for the PO leadership participating in QI. And one core, we're now going to call them core meetings. So CO for collaborative and RE for regional meetings. One core meeting is required for PO leadership not participating in QI, and the QI participants are encouraged to attend one of the core meetings. Did I express that correctly, Diane?
You did.
Okay, next slide. Again, simplify things. Webinars. So it's interesting, at these meetings, at the regional meeting, we had Dr. Rodnick present, and he just did an amazing job. He's a chiropractor. I think he's on the line, and he's really helping us out in lots of different ways with regards to this collaborative. And what I loved about his presentation is he had a stack of studies, and he went through one study after another. Well, this study says this. This study says that. This study says this. And so we were able to have discussion, about what these studies show and how that affects practices, and what our plan should be going forward. It was very well received. We had really high reviews for his presentation. And again, one could argue that that's mostly for clinicians, but at the same time, it's reasonable for PO leadership to hear that and to hear what some of the discussion items are. And I think the PO leadership that was at the regional meeting that wasn't clinical still enjoyed it. So at these meetings going forward, we do plan on having speakers because we think that keeps things real and it helps to further our education. But similarly, that's probably not enough. And if we look, we had some initial training through Spine Care Partners training that started in 2021, which is one of the Jeopardy questions. And the training has several elements, and each of the elements are evidence-based, and we know that. And so while we're trying to, again, determine the secret sauce, or what's going to be our best protocols going forward, and are we going to have a new best practice that's going to emerge, at the same time, we still want to reinforce the best practices that we already know. And that was the information from the training. So giving training to people once, as we've done, is helpful, but we certainly want to reinforce the elements. And a lot of this is what the webinars are about. To a certain degree, this will be some of the speakers at some of these meetings as well. So, we've had Dr. Leonard speak, to give the chiropractic viewpoint. Again, great presentation. And again, one could argue, why would a PCP need to know about what a chiropractor is doing? And I would argue, that a PCP is probably the most important group of the most important person that needs to know what a chiropractor is doing, because that's what this project is all about. Chiropractors know what chiropractors do, right? So we want to give everybody representation, and we want to learn what each other is doing. So we had Dr. Leonard speak as a PCP. I thought it was very helpful. Had Dr. Pasterman speak on medications. Again, chiropractors don't prescribe meds, but it's really helpful for them to know what meds patients are taking and how it does influence their care. And then going forward, we appreciate Dr. Mogadam and I believe Alicia and others are working on coming up with a plan for webinars for this year to take it to the next level. And we plan to have a chiropractor and a PCP speak, so we can see the juxtaposition of the two, what each one does, how they interface with each other, so we can again further discussion, change the culture, and you'll know that as a team, there's a place for all of us and we can work together. And then we also plan to have a DO present on osteopathy. Now, we don't need to know all the details of exactly how to practice osteopathic manipulation. It's not appropriate for us all to learn, but the history of osteopathy, what it means, how it affects all of us, some evidence to support its use, that would be helpful. Because again, this is just an example of all of us being aware of all the key modalities that are available, particularly as we're trying to come up with best practices going forward. So dates, specific speakers are coming, and if anybody has any suggestions for future webinars, let us know, but we wanted to fight our case as to why this is important. Next slide. And so the next slides are for reference, and I am right on time. So we have those reference slides, including, and we can come back to those at the end during Q&A if needed. But this is kind of our vision statement, which we were hoping to go through in more depth, but we figured it would be more helpful to spend time during the breakout sessions. And so next slide. So for the breakout groups, and let's cross our fingers and hope this goes okay. It's actually been a little funny because we didn't think we could assign breakout groups at first because there was a WebEx glitch. Then, Diane and the team did assign breakout groups and have had multiple meetings to ensure that the technology worked. And then we got this email from Diane this morning that all these breakout groups that you so diligently assigned got wiped out. So it sounds like you have to self-assign, and there'll be a next slide that shows you how to do that. Here's Diane's phone number that you can text if there's questions. I'll appreciate your patience in case there's lots of texts. Sounds like you'll be muted when you enter the session. The facilitator will request to unmute you, which is too bad, but I think that's just how these breakouts have to work with WebEx. And then you can use the raise your hand feature. And typically we have the plan is until 10:20, and we want each group we have facilitators for each group, but we want really just a few bullets of what the group decides, and then a 3 to 4 minute report out at the end. And this will be kind of like a rapid fire report out, and then we'll open it up for questions. Oh, thank you. Yeah, there we go. It's the next slide. I was ahead of myself. And so several groups intentionally have members with diverse roles. We appreciate everybody's discussion. We want open discussion, and we don't necessarily need to solve everything today. This is just to get the discussion going and to facilitate future discussion, on each of these topics. Next slide. And so here are the 4 breakout groups. Metrics and measures is group 1. Defining chronicity is group 2. Reporting success is group 3. And disseminating knowledge is group 4. And each of these came from our vision statement. So each of these are key elements from that. That's key for the success of the project. And now probably the most important slide of the day is the next one.
Yes, so I'm sorry, I'm going to interrupt for a second, Steve.
Please do.
Everybody, please look at the slide that has your name on it. I tried to put them alphabetically. Like Steve said, it was a lot of last minute adjustments. If you did not if your name is not on these slides, or if you just registered yesterday or this morning, feel free to join any of the groups, but please remember the name of your group. So group 1 is metrics and measures. Group 2 is defining chronicity. Group 3 is reporting success. Group 4 is disseminating knowledge, because that is how they will be identified once I start the breakout groups. So let's see from there. I am trying to, okay, so I am going to start the breakout sessions. If anybody has a question, please put it in the chat or text me if you remember my phone number. Again, it's 248-736-2921. I am also monitoring my email, which most of you have, or you can email mybac@hfhs.org.
Diane, can you hear me?
I can. Oh,
Jeanette Jankowska has been trying to get in all morning.
yes, I'm emailing her right now, and I have multiple people that can't get in the breakouts. So yeah, I'm trying to get her in.
Okay, great.
People can't get into these breakout groups. I don't know what's
Okay, thank you.
All right, thank you. So how many people do I have that aren't in breakout groups? I have Angie. I know I have Leah, and I'm trying to look at who else I have here. So what I can do, since I can lead my own mini breakout group, is I can kind of go over some of the topics that we're going at the others, so we can kind of do a multi topic breakout group. So I'm going to reshare my slides just because it helps me to stay on task. All right, so where did my navigation slide? There we go. Okay, so I will go over, and now my chat went away, so hold on, let me open that just in case any of you have questions. By the way, if anybody is wondering, I am never using WebEx for a webinar again. It's incredibly frustrating. So, and I sincerely apologize for all the difficulties. We had it all worked out yesterday and everything changed overnight. So metrics and measures. So what the first group is working on, and let me see if I can unmute. I think I can unmute you individually. So I'm Angie. I requested Angie to unmute and Leah to unmute. Are you guys able to speak now? That would be too easy. Well, I'm going to present because it's the best that I can do at this moment. So I sincerely apologize. If you have questions, please put it in the chat. I can see the chat now. And I'm hoping that you can all see the chat as well. So metrics and measures. So one of the things that we're working towards in the collaborative is how are we going to measure progress? How are we going to measure what those best practices are going to be? And there's a lot of challenges around this. There's challenges based on claims data, for example. So claims data can show us some things. It can show us things like after the patient saw Dr. X, did the patient get an image within that first 30 days? So the HEDIS measure is in the absence of red flags that you shouldn't be doing imaging in that first 28 days. And there's a large, long red flag list, and I am happy to share that with all of you if you are interested in seeing that. But obviously we want docs doing imaging if it's necessary. However, we want to reduce the number of images. So one of the things that's possible is looking at that. There are challenges with that, however, and the challenges include things like, okay, if we do a measurement year, so let's say we measure from January 1st of this year to December 31st of this year, we run into this. We obviously have to do the 28-day run out because it's ordering an image within 28 days. And then we have a 3 months run out for claims. So that involves, a lot of times, as you guys probably know, claims can go back and forth. There can be requests for more information. So things do take some time on that end. And then we get the data and we have that analysis time, which can be anywhere from 3 to 6 months. So the delay is there. So that is a challenge as far as if I'm a clinician and I am performing and meeting my metrics, that may not be evaluated for almost 2 years. So it can be a little bit of a struggle to keep people motivated based on that. So, and I'm watching my time just to see when the webinars should be up, which should be 20 after. Okay, we're good. So that is some of our challenges with the claims data. Another method of getting information on progress and best practices is doing it from the registry. The registry is a challenge right now because we aren't auditing at a level that will make that data usable. And when we say auditing, it is chart review. So there will be some updates in that. And part of that is getting that message across to everybody. We are not challenging anybody's integrity. Auditing is an essential part of a registry, and kind of explain it to you, and you can explain it to your colleagues and your teams, is that if you're being measured compared to the aggregate, which is the group, you're going to want to know that everybody else is doing what they say they're doing. You're not going to want to be measured without everybody being held to a certain level of scrutiny, because that can impact your end status with that. So if it's a VBR and you're looking at maybe getting 5% VBR, if you met this measure, if somebody else is not entering the information correctly, or let's say they're only they're cherry picking their patients, you want to be aware of that. So that is the purpose of the auditing. And
I think it was how it was presented. Auditing has not go over particularly well this year. And again, we are trying to call it chart review because the word auditing kind of freaked people out a little bit. But it is not meant to challenge anybody's integrity. It is not meant to take up a bunch of their time. It is a necessary part of any registry. So this is an all-payer registry for the state of Michigan. It's very important that we have people entering the data correctly, that there's not a lot of typos and errors with entering the data, which we're all human, so errors will happen, but we want to keep those minimal. So group 2 is defining chronicity. So this is a pretty exciting group. This is what I wanted to have you in, Leah, but that's okay. So they are discussing what are the definitions of chronic. So chronic, what MIBAC started with based on some of the research was no recurrence of back pain within 6 months. Yeah, we hit it by months. 6 months following the initial visit. Well, there's other ways to evaluate chronic. And I know in my world as a physical therapist, chronic was 3 months of not receiving, or sorry, 3 months since they started receiving care of back pain. So it does vary, and we are very interested to get feedback from our clinicians about how they define chronic, and do they have research behind that? How are they defining that? Are they doing it just based on the insurance rules, which is quite common? Or do they have actual like data to support that? And then there is the whole issue of cause and effect versus association. So MIBAC is not obviously a research project, so we will not be able to determine cause and effect. We are looking for associations. So that is where we're really going to need our clinicians. And when I say clinicians, those of you who work in practices that aren't clinicians can also help by giving us information because you're around the patients. So you guys might see some of that cause and effect even more than some of the practitioners. Like these patients got better, and these are all the patients that that the doctor had me go in and recommend massage therapy to on their behalf, or these are the patients that the doc asked me to give these educational materials to. So those even can be some of that association. Those patients seem to do better, or the patients that come in and ask for opioids don't do as well. And those are just hypotheses. They may be very different, but we're very interested to see in the long run how that works. And we really need everybody's input on that. So right now we are using the Promise PI based on just a lot of research. Oh, there's Jeanette, yay. Okay. Based on a lot of research, the Promise PI is a great tool. It combines things like anxiety, depression, function, self-efficacy, all in 4 questions. And originally we were doing a longer Promise PI, but the research shows that the 4 questions captures the data just as well as the longer form. So we were able to switch to a shorter version, which is lovely because patients don't want to answer a super long form. And so we really want to get that back. So if you guys were to encourage patients that are resistant to just complete one survey, the Promise PI is the way to go. It's how we're going to measure these 3 things, led to a decrease in patients that are defined as chronic at the 6 month, at the 3 month mark. However, we end up measuring that. Most likely, it looks like it's going to be at the 3 months, just because we don't have as well of survey follow-up by the 6 month period, which makes sense. Further you are away from the problem starting, the less likely you are to respond to those surveys. So, but that's kind of part of the reason too why it's incredibly important that we get survey responses. If we only get baseline surveys, we will not be able to determine cause and effect. So all we'll be able to show is that Dr. Jones saw this patient and they had a super high PI score, which high score means they have a lot of pain interference, which is not ideal. We want to get that score down. So and I know Steve brought this up earlier in discussions, but average population score is around 50, and we are proposing 53 for this population. And right now, the bulk of our practitioners are hitting it out of the park based on that measure. So they're doing just fantastic. So we feel like that would be a fair goal and a good goal for getting those patients at that 3 months close to the value of the normal population, because we also realize that back pain doesn't usually completely go away. Sometimes it does, but often people learn to deal with it better, learn to function despite the pain. And those things are super important in preventing chronicity, because the more they function despite the pain, the less likely it's going to come back in its initial severity, and the less likely they're going to become obese, decrease their activity level, increase their blood sugars and blood pressure, all of those things that go with it. We're not going to be proving any of those individual things at this point, but I think we all know that a lot of those things are tied together, and there is research to show that. So reporting success, I would love to hear from all of you, everybody on this entire meeting. We are trying to develop reporting that is meaningful for our PO leadership and our clinicians and our site help, which can be an office assistant or a medical assistant or a nurse, somebody at that practice level that is like, how are we doing? So in that group, and again, I apologize that you can't get into that group, but I was supposed to be on that group, so I know a little bit more about that group. But so Keith is one of our data analysts, and Samantha and Kyra are the people actually doing the chart reviews. And so they have a lot of association with people asking for information. So we would like to know, what is it that you want to see? Do you want to see, we hear a lot about they want to see how they're performing compared to the aggregate over the overall population. And I do think that's beneficial. And we are, Samantha sent out some reports based on enrollment and how many patients, for example, how many patients in which the practitioner has completely submitted the clinical form, because that has been a challenge. The buttons were confusing before. They did update the buttons, so now it actually says submit on the button. It said save plus before, and it was confusing. I didn't know what to do the first time. So but kind of compared to the aggregate. And then the other question that seems to be a challenge is, and we understand it now, we knew what it meant. It's one of those things where you know what you mean until you ask other people. A lot of times you don't realize that they don't know what you mean. So the question was, how long has the patient been having the pain? And we are looking for that length of time for this acute episode. So even if it's a flare-up, we want to know the amount of time for that acute episode. So it shouldn't be greater than 6 months, or it's by definition not an acute episode. So we've had a lot of people mark 6 months, I think the option is greater than 6 months. We did update that question to say the patient is not eligible. Please refer to the eligibility details. And so that is one of the questions too, is how many people were marking that. Now, when we did the chart reviews, we found that 99% of them, and I didn't do math, I just, from talking to Samantha and Kyra and being on some of the audits, but 99% of them were acute episodes, and we were able to adjust those dates. It's just a confusing question. So kind of educating out on our end as far as what we mean by that question is one of our foci, there we go. Right now, so that everybody can be on the same page and answer that question and make sure all of those patients, quote unquote, count. We are not taking patients out of the count based on that right now, so do not worry. We also do not want people to go back in and change their entries. We ask that if there's an error that they find on their entry, that they email us, and we keep a very detailed record of who changes those entries and when and why. And the reason for that is so that nobody comes back later and says, oh, you were not performing well and you went in and entered or altered your information to make your performance look better. So that is not what we want, obviously. So, and let's see. Trying to unmute Susan. Hi,
Can you
Susan.
hear me, Diane?
I can. How are you?
I actually have a question for you.
Awesome.
Okay, so if it is a chronic patient with an acute flare-up, how would you like them to answer that question? When the acute flare-up began? How do you know it's
Correct.
chronic?
So a chronic, so you'll ask the patient, so as a physical therapist, how I would handle that, and I'm watching my time because if you've got 2 minutes, but how I would handle that was I would ask the patient, they'd be like, oh, I've had back pain for years. And I'm like, well, you haven't been receiving treatment for 2 years. So what changed and when? Well, I started having pain going down my leg 3 months ago after I lifted a heavy box. So that would be the date of this acute flare. So if they had a 1 out of 10 pain all the time, but all of a sudden they're having a 4 out of 10 pain, when did that happen? It doesn't have to be a why, because a lot of times there isn't a why, but when did that change happen?
Okay,
Yeah, so it's hard. So we need to put together some scenarios. It's on my list. Unfortunately, this week I spent like 10 hours playing with WebEx only to have it completely fail on me. We will be using Zoom next time. We don't have a Zoom account and we're supposed to use WebEx, but it is not worth the stress. So I apologize for the issues today, but I would have loved to do some of these things this week. I wasn't able to due to time. So that is on my list because it's very confusing for practitioners. Like, like what is this? What is this? What does this mean? Why are you asking this question?
so Diane, so just to clarify, they should never be choosing greater than 6 months or they are not eligible.
Correct. And that is, oh my gosh,
Okay.
my slides. Whew. Okay. Hold on. Okay. Can you still hear me?
Yes.
Okay. And that is on the question now. It does say, oh my gosh, my computer's completely failing. Sorry, I'm trying to end the breakout sessions for the others and I can't. There it is. So it is on the question now. So the options are the same, except for the last option says, greater than 6 months, this patient is not eligible. Please see enrollment criteria.
Okay.
So that was meant to assist with that. And let's see if it lets me stop sharing my screen now. It won't. I cannot stop sharing my screen. So I cannot tell what's going on. I love WebEx. So we shall see. Do you guys have a timer saying you're going back to the group?
No.
No, okay, because you guys are in my group. Let's see if the main menu the main meeting starts up again, because my computer will not let me stop sharing now.
Up at the top, Diane, it says all breakout sessions will close in 20 seconds.
Yes, thank you. Perfect.
Okay, and there's a countdown. Okay.
Perfect. That is what I wanted to hear. And my slide presentation is not working. It let me out. Okay.
Diane, can you attach the criteria, the enrollment criteria then? You know how you're going to load all that on the all those documents? Can you load that document also? Or is it already out there?
I certainly can. It is out there, but I'm always happy to attach it. I think it's super important. And just to announce to the entire group, a lot of people could not get into their breakouts. So we had a mini breakout group because we could not get them in and my screen has been going ballistic. So I couldn't stop sharing my screen for a while. So everybody's been super, super cooperative and I will never use WebEx again for a webinar. So lessons learned. So I'll pass it back to you, Steve.
So thanks very much, Diane. Again, anytime you do a virtual meeting, particularly when it involves complexities such as breakouts, it's not a question of if, but what is going to go wrong. And if y'all remember that we had that webinar last year where there was an issue and we couldn't share our screens, and I literally took one computer and held it up to another computer and displayed the recording of the webinar that needed to be played, like old-fashioned, manual process. And it worked. It wasn't perfect, but it worked, and everybody was flexible, and didn't get any complaints, and so we all recognize the challenges. So
Yes. So the answer to what could go wrong today was everything.
well, group two was able to meet.
We
Go
got
ahead.
40 minutes left.
Yeah, group two was able to meet. So yeah.
Mary. All right. Thank you again, everybody, for being so patient. We really appreciate it.
So our next steps is we plan on doing the report outs. I guess we can not share screens if any. I'm not sure how this is going to work given the challenges and breakouts, but we'll be flexible with this. So we'll try to do report outs in whatever version that we can. I know group two was able to meet. We had some really good discussion, and I'm certainly happy to give the report out on that. We'd like these to be we want everybody to give a chance to speak. So we'd like to do the report outs first with whichever groups we're able to meet, and then save your questions until each of the groups are able to report out, which may only be one or two from what I'm hearing, and then we'll open it up for questions and discussions to the larger group. So does group one have anything?
So yeah, we met with a few of the people. We could not unmute everybody, so I don't know really what was going on with that. So I apologize. We had a few questions that we did pose for the metrics group, and 3 of our attendees were able to be unmuted and did give some discussion. So one of the questions we had asked was for the metrics that we have, are all the data points really necessary or unnecessary? And they thought that the ones that we had were good. Obviously, we always could add more, but we didn't know if it would be easy to collect and obtain in that aspect of it, but they did appreciate the ones that we do have for the questions that we do ask on our sheet. Also, it depends on obviously the practitioner and the physician or the chiropractor who's doing what. The second question we discussed a little bit was if adding more data points would add more variability. Would it add, what would it really add? And we couldn't really come up with yay or nay in one direction or the other kind of aspect of it. And then the last question was, how do we get our data points? So basically, because if there's imaging or referrals that were made, how would we find them if it's not in claims data, or would somebody have to go in and actually go through each chart to review it in that aspect of it? And then also like a discussion about how if a physician or chiropractor orders a test and the patient doesn't get it done, what goes on in that case that they still haven't, they don't get, do they get dinged or not, or how do you go through and see anything? So we were just discussing that kind of aspect, and then we got cut off. So
That's helpful. And as I think about this, actually, Alicia, do you mind sharing the screen again and going to slide 35? That if any group leader wants to share the screen, we can always break away. But if not, it'll be as I know I suggested not sharing, but as I think about it, it'll be good to have that visual. So lots of questions, from this group, and lots of things that we're working on. And again, it's like you're saying, how to measure, right? How do we define an X-ray? Is it when you ordered it, when it was actually done? Is it, and I guess it depends, how can we get the data? Is it from patient IQ? Is it from claims? Patient IQ is a lot easier, but it's only a subset of the population, whereas claims is a much more all-encompassing, larger group, but there's a tremendous data lag, and it's so challenging to get information from claims. One of the things that we did within the patient questionnaire, or sorry, within the clinician questionnaire within patient IQ, is we tried to be intentional with several of our questions, as you know, and we try to have the red flags in there as reasonably as we possibly could, recognizing that, of course, it's always appropriate to do, always reasonable to do imaging, per clinician judgment in the setting of a red flag. If a patient has a red flag, imaging may be needed. So that may help with that. Thanks so much, Dr. Mogadam. So it sounds like there are some discussion items and several questions that need to be answered with regards to that. Defining chronicity, that was our group, we had some really good discussion. And again, we displayed that promise PI graph, or the promise pain interference chart, which again showed that the population at average, or we defined or is defined as 50 for a pain interference score, and we were somewhere around 68 when we started, and it dropped to very close to 50 at actually the 2 to 6 month mark with usual care. So reality check that most of our patients get better, or at least the average patient gets better in time. And so the group, after some discussion on the Promise PI, on the concept of the minimally important difference, the article it came from, and the definition of chronic from a time standpoint, and appreciate Dr. Larry Cowsell's input on that and others. We agree. We agree to stick with this definition of chronic pain, which is a Promise PI score of 53, which is the average plus one minimally important difference. We discussed other possibilities for future analysis, and there was a lot of discussion on the start back. Dr. Lundgaard, Dr. Van Gessel, had commented. Dr. Lundgaard's team is already using the start back, and interestingly, they're not part of our pilot, so they've kind of figured out on their own. They did it 2 years ago, the start back, and that's what this collaborative is about, right? We want to people that have figured things out. How do you operationalize it? What are the best practices? How does it work? Clearly we appreciate you speaking up, because we'll pick your brain in the future with regards to this, and certainly analyze your team's data, because if the start back ends up being a best practice, we're gonna need to figure out some of even more of these details. What are the best practices within the start back itself? So there's a lot of hope with this start back. That this might be one of the key answers to our program. And Dr. Van Gessel pointed out that United Health was using this and requiring this as part of, I think it was a clinical report at one point. So that was pretty helpful. So at any rate, very robust discussion. I felt like we could have discussed a lot more, but obviously in the limited time we have, it's neat that we have a definition of acute to chronic, and it's neat that we have ideas of things that we can analyze. In fairness, I know I need to turn it over to the next group, but I brought up and I said, hey, at this meeting, why can't we display graphs now and show them, patients that were referred to chiropractor or physical therapy or any kind of intervention, versus the population at large. I want to see those graphs now if there's a difference, but I was advised that I need to slow down, and that the data is not robust enough at this point. And if we start displaying data with the, statistically insignificant sample size that we have at this point, that it's just gonna not be very helpful.
I
So,
don't know who told you that.
but then everybody echoed what you said, Diane. So at any rate, at some point we'll want to see these graphs, and I'm itching to see them, but I recognize it's too early to do that. Anybody else from group 2 want to chime in on something I missed? Okay, group 3.
Group 3, reporting success. We went over some updates to the provider dashboards and the PO dashboards. So provider dashboards, we talked about just some ongoing issues with providers logging in. We can kind of do a workaround. So if you're having issues, to send a ticket to us, and we'll be able to assist with that. There's also been the provider portals weren't showing an accurate count of patient enrollments, just the way that the patient IQ report was pulling. They were pulling the completion date rather than the submission date. So things that were kind of happening on the back end that made it a little confusing. So that has been addressed and corrected and will be updated shortly. And just a reminder that the patient IQ, the provider dashboards are pulled from a report that the data team gets every Tuesday. So the provider dashboards are updated every Wednesday, close of business. And then we talked about PO dashboards. There's some really great updates that Keith and Mary are doing just to make it a little bit more user friendly, and show like total enrollment progress for each practices, so POs can kind of focus in on different practices. And then we didn't have too many, or we didn't have too much of a chance for discussion, but we would hopefully like some feedback just from PO leads, what reports are helpful and at what level. So kind of like the frequency of how we can send out those reports, focusing in on different things like in the future, obviously focusing in on more best practices, like how certain practitioners are doing compared to collaborative wide totals. So that's more in the future, but in the time being, we would love feedback for any reports that would be helpful at the current moment. That's kind of what we touched base on so far.
Thank you so much, Samantha. Was group 4 able to meet?
We were. Dr. Holland, would you like to share what we discussed in our group?
Oh, I thought Samantha was, she had bullet points, but I also have some. Would you?
Samantha wasn't in our group. Melissa?
I mean, Melissa, I'm sorry.
Yeah.
Melissa.
It's all good. Samantha and I look very similar. I will take that as a compliment. So in our group, we talked about different ways of communicating within the organization. So within the chiropractor practices, within the PCP practices, what they're doing there to share information from like monthly newsletters and tip sheets. We also talked about how they're communicating from a patient perspective and talking about MIBAC. Dr. Lupo brought up a good suggestion of having closed circuit televisions and being able to share information on there with his patients, which we thought was a great idea. We also talked about an automated newsletter that they have and how we can share information through that. But we did talk about how information on MIBAC, sharing something within the practice face to face is probably the best and easiest way to communicate from a patient perspective. We also talked about different ways to communicate from outside the QI, so different associations we should be reaching out to. Sherry was kind enough to talk about the PGIP, different ways to connect within PGIP, whether it be the record or the value partnerships monthly newsletter. And we also talked about different seminars we can be a part of, and developing a quick little promo potentially that the doctors can share whenever they're talking or presenting in front of different associations. And before, we couldn't get to our last slide, but it was a great discussion. And Dr. Helen, did you have anything else you wanted to add from there?
Well, I thought that everyone had some good input, and again, the role of our leadership here with the champions and our new board will be to help provide this information across the state with disseminating what we're doing in our QI. How can we build our QI? How can we get more patients registered? How can we meet our goals of measuring and in all of this? So with our group, with disseminating, it will be evolving as we find out what's working and how our patients are responding and receiving the information and what works for them. So one of the good inputs we had was maybe perhaps having a survey monkey. What works for the providers? What do they like doing? What works for the patients? What do they like receiving? So as we work through this, we'll find out more.
Thank you so much, group 4. So now we can open it up for questions. And Diane, there was a question in the chat. I think you said that we'll have Q&A and somebody could be first, right?
That was an error. She did not mean to raise her hand. So we can go ahead and open up for whoever has questions.
And again, you could either put your question in the chat or you can raise your hand. We do encourage discussion. We know it's a little more challenging virtually than in person, but well, I'll start with the question. I don't see a hand raised yet. And then depending on how the Q&A goes, we could even go back perhaps to that vision document and then briefly discuss at least the wheel. Well,
We did have a question in my impromptu breakout session, and the question was from Susan from Great Lakes, and it was some of the confusion about how to answer the duration of symptoms on the clinical form within patient IQ or whether you're doing it on paper. And it is confusing because you get a patient that's had back pain for 2 years, and you may have seen them 2 years ago and they're doing super well, but something happens or something changes and they come back to see you. So what we're really looking for is that change. So as a physical therapist, and I'm sure all of you have some of the same experiences, the insurance companies really want to know, why are they here today? What changed? And sometimes patients have difficulty, and we do have a question in the chat now, but sometimes patients have difficulty in verbalizing that. But I kind of will ask them, they'll say, oh no, it's been going on for 2 years. And I'm like, but why are you here today? Why weren't you here 4 months ago? Like, what has changed? And usually they can then define something. Oh, it's going down my leg now. Or, I lifted this box and the pain's been increased since then. It happened 2 months ago. A lot of times it's I don't know. It just started hurting more at this point in time. So pinning down that in time is super important, because again, enrollment eligibility is for patients that are having an acute episode or an acute flare. And it can be acute on chronic, a patient that's been a chronic pain patient, but was doing well, managing their pain, and something changed. So we're looking for that change date.
So there's a really interesting and really good question in the chat from Dr. Colvin about adding someone from mental health. So it's interesting. One thing I neglected to mention earlier is that one of the webinars we had last year was from a mental health professional, Dr. Tolvin, I think her name was. And she was great. Also, it was very well received. And so again, that's one of the tenets of the training is addressing mental health and the language that we use, to help help our patients. I'll tell you, in my experience, patients often find happiness with their chronic back pain when they come to acceptance, which I know sounds kind of crazy, but they're fighting, doing everything they can to try to prove the pain, as they should, but then they get angry that they're in pain. And at some point, when they find acceptance, I find they often find happiness again. And so I'm oversimplifying things, but that's my personal experience. But so even though we've had a webinar, what other role should mental health have, and somebody that has a mental health background or degree in the collaborative? And as Diane pointed out, Samantha is a social worker who's helping with resources and helping with the Start Back program. Dr. Colvin mentioned, though, could this be a position on the executive committee? Very interesting.
I think that's a great idea.
And the question is, could that be one of our specialists, or maybe we can dissect out and specifically have a specific role for that? I also think it's a great idea. What do others think on that? And again, raise your hand, put it in the chat, comment. Okay, so silence from the group, but Dan and I agree. Great suggestion. Thank you. Thanks for typing in.
Thanks, Dr. Lundgaard.
So I have a question. So I think one of the groups mentioned about this TV, closed circuit TV, right? And so that was about, I think it was Dr. Lupo had that suggestion. So this was about educating the patients, right? So there's different parts of this project. Once we come up with best practices, it's going to be about educating the clinicians, but then it's ultimately going to be about educating the patients, right? So I feel like the clinicians are going to need to know how to educate the patients, or we're going to have processes and procedures to make this worthwhile. So it's the suggestion that, like for me, my vision for that when I hear this, and I just want to make sure I understood this correctly, was within, say, like the Start Back pilot, where somebody that may have a higher risk for developing chronic pain, so they come out a higher risk on the stratification tool, maybe there's some kind of video that's played in the exam room, or I know the team has talked about the possibility of some QR code, that they can use on their personal device or something like that to watch a video on back pain. Is that kind of what the group was describing that talked about closed circuit TV, or was there a different vision for that?
Dr. Lupo, did you want to describe what you were doing in your office, or did you want me to comment? Well, what I took from it was that it would show the benefits of being a participant in the program, that their work would help others to understand the pain and the options of care and understand what we're doing to help the whole Society of Patients with Back Pain to prevent
And
chronicity. And
Linda, I did unmute him. CJ did
you
ask to
did?
unmute,
Okay.
yes.
Okay, this is Dr. Lupo. What I was saying, your idea with the QR code might even be better because you could use that anywhere. It could be ubiquitous for everything like that. I was just mentioning that I built some closed circuit TV thing in our office that I could post things on in real time whenever I wanted to. Like I could go right here and it'll be playing in our office right now. But yeah, I think your QR code is probably like something that could be used by anybody anytime. That's a really good suggestion.
Yeah, and I don't want to take credit for that because somebody else, like Linda, was that your idea? Somebody from our CC came up with that.
Oh, well, I like to QR code everything, but it really was with the Start Back, with the program that they had in the UK. They had some videos for the patients to watch, and then they had training videos for the doctor to watch how to communicate with the patient in those risk categories. So I think if you have something in the room for the patient and they're in the risk category that is mild, you might have a video for that, or on that loop that Dr. Lupo had, or maybe somebody that's in the high risk so you can calm them and have them understand that you're working with them and you have ideas that can help. So we used to have what happens at the chiropractor, that introductory to the visit when the new patient came in. This might be something that you can add to it. So if we come up with a little blurb.
Yeah, so it's interesting. So maybe all the above, right? So a QR code that you can watch on your own at home, depending on the situation, a TV screen if one's available, or a computer screen that you can access the video via QR code or some other process. I feel like the more options that we have to display pertinent, important information, the better, because then it can be adaptable for different physician organizations and practices, across the state. So I guess I have a few things in follow up on that. So I guess for chiropractors, you're more likely to see patients with back pain on a regular basis. So to your point, you might display this for most, if not all, your patients. As a primary care doctor, it wouldn't be appropriate for me to display this for all my patients, right? You come in for who knows what, and I'm saying, well, just watch this video on back pain, right? And so I feel like that might be where something like the Start Back comes in, or there's some trigger, for this QR code or video or something along those lines. But I'm curious, what's in the video? Is there a video already made? Do we have this? Is this something that is proprietary? Is it best practice? Can we share it? Can we look at it? Dr. Colvin has his hand up. Let's see. Let's unmute him. You're unmuted, Dr. Colvin.
Come in with acute and chronic back pain. So I don't think it's necessarily inappropriate to have that be something that does loop through. Just like right now in our exam rooms, we've got video monitors that we can edit some of the material, but not all of it. But it loops through, diabetes and hypertension and hyperlipidemia and eye exams and all this other stuff. It doesn't mean every patient has those diagnoses, but it's astounding. Almost 100% of my patients that come into the office are playing on that video monitor and looking at information on there. The other idea that I've got is you could also have small cards made that had the QR code printed on it, and maybe 10 quick facts about chronic back pain, or 10 resources, recommendations, and just having those available in the office, even from a primary care standpoint. I think it would be surprising how many patients would pick those up and still look at the QR codes at home, give them something to think about, something to come in prepared for follow-up visits. It kind of gets them out of that mindset of, oh, I have back pain, I need an MRI, because that's typically what I hear when patients first come in. As far as videos, I know that there are some videos out there. I don't know that any of them have been, made directly, but I've seen, videos from other places in the past that do kind of talk about back pain, and this could be your causes. So I think a lot of that material is out there. I think it's a matter of how do you get your hands on it and how much of it is already, protected or has proprietorship.
I like this. You bring up really good points because you're right. Even within Henry Ford Health, we have looping videos or looping. I don't know if I think they're videos maybe in the waiting rooms, but in the exam rooms they have screensavers, and so it's a little bit challenging, right? Because I think there's a whole committee that approves what can be on those screens and what can't, and so I feel like we'd have to have options, right, for different POs and practices where to your point, you can just loop the video in as appropriate ahead of time. I think that's totally reasonable, what you said. But also QR codes. I guess my vision for this as I'm thinking is, yeah, if there's videos that are already made, perhaps of different lengths, right? So maybe there's a 1 or 2 minute video that loops in on that TV screen while the patient's waiting. Maybe there's a 15 or more minute video that we specifically assign to a patient who's higher risk on the start back, or something along those lines. Is there anybody that's using that's using videos that has advice on where we can dig and where to find this?
I think patient point is the monitors that we've got in our exam rooms, and there is some information on back pain on there. Again, the problem is you can kind of pick and choose parts of it, but you can't necessarily put your own custom video in there.
Okay. Personally, I'd rather not reinvent the wheel from an expert that's done something already and has figured something out. Um, so more research to come. And again, please send us messages, emails, information, anybody that happens to come across videos, particularly if they're non-proprietary, or even if they are, I don't know, we'd have to figure out how to work around that. Because again, this could be a best practice throughout the state. If nothing else comes out, our best practice of the collaborative could be patient-facing videos, and if that's demonstrated to show success. Other comments or questions from the group? Can you go back, Alicia, to that slide 30? I just want to comment on this wheel, and can you put this in presentation mode? So without going into all the details here, I just want to, oh, maybe you bounce back out.
Hold on,
Oh,
I had to stop sharing to put it in presentation mode. So give me a second.
okay.
It's not cooperating, so so slideshow, current slide, and share screen. Okay, it is not going to let me do that
Let me
right
try. I'll try myself. Is it working?
now. Not working for me.
It looks like it's sharing. Can you guys see it?
Yeah, I see it.
Okay.
Oh, really? I can't see it.
So
Okay, good.
I,
I'm not
I
going to
just
touch
shared,
anything.
but I can't see the chat. Let me see. There's a way to do that now. Let me move the chat over here now. Okay, so here's our vision again. So we have those 3 program goals, but it's this overall goal: prevention of chronic low back pain among patients who present with new episodes. And again, this first part of the wheel here is this established metrics that we're looking at, or update the metrics. Well, we had group working on that. And then once we come up with these metrics and we're already working on this, are we asking the right questions? It's this analyzing data piece. Can you guys see my cursor? Okay. So again, this was more my group. How do we analyze the, Mary's group? How do we analyze the data? Let's look at these graphs. How do we figure out, what are the things that we're going to want to look at? And then it's this creating reports and dashboards for the team. Again, we had a group that was working on it. And then as we go through all this, well, what are the best practices, right? Maybe it's start back. Maybe it's use of this video / QR code, with different ways to access it, right? Wouldn't that be great? I feel like the best practice is going to be something super simple. Again, not sure what it is, but it's going to be something simple that we're all going to say, aha, we should have figured that one out or thought about it, right? I keep bringing up how MIBAC, their best practice, or one of theirs, as I've heard, was get patients up and walking soon after surgery, right? All this time and effort, and that's what they came up with. But that's amazing, and it's made such a difference in patients' lives. And then once we come up with this best practice, then again, how do we disseminate that to the teams? And so that way they're aware. So in this case, as using this as an example, say the video works out to be a best practice. how do we get this and spread this, scale it throughout the state? And then how do we make it easy for the teams to actually implement the best practice? And then once we do this, well, we're really not done, but then we have to measure. Is it working? Is it not, working? How do we analyze, create new dashboards, et cetera? So this is just a, this continuous PDSA cycle, going forward. So this is kind of our vision for this. I think it's important to look at this so we know we have our eye at that so-called North Star. And then to go into this one, I know this is pictures are easier to look at than words, but I just wanted to at least discuss the the key sections here. So again, prevention of chronic back pain, acute back pain is common. Chronic back pain, and the key word here is preventable. In many cases, that's why we're doing this. Existing state, we're not necessarily following guideline concordant care. Clinical hypotheses, fewer patients will develop chronic back pain with certain interventions. We don't know for sure what they're going to be. That's what we're studying, or I shouldn't say studying, we're evaluating. But in addition to this clinical hypotheses, well, what about clinician behavior change hypotheses? So say this exercise, or say this video that we come up with turns out to be a best practice. Well, then how do we get clinicians to use it? That's a totally different thing. And thank you to Dr. Narens for pointing out these distinctions, because that wasn't clear to me, until you pointed it out, but it's so important. What are the most important things we can do? And then how do we train our teams to actually do it? Totally different things. I've struggled with this, in my role, in leadership at Henry Ford Health. We try very hard to get information to frontline docs, and we don't always succeed. But there are some best practices, so that's something we have to evaluate. And then this metrics part, what are we going to measure? Right? So then there's clinician data entry, which are basically the clinical elements on the patient IQ form, which is up here. But then we also have questionnaires, which I think we're just going to be like, once a year at this point, saying, well, how comfortable do you feel treating patients with back pain? That's important. And then we're looking at the patient information that they're going to enter. And then this is more challenging, the claims data, but this will be helpful as well. So these are all the things that we're looking at. So let me pause. I know I went through that a little bit quickly, but I tried to do it very high level. Any comments, questions, thoughts on the vision? This is basically the basis of our discussion in our breakouts today. Okay. Well, we will send these slides out, right? Okay. Now there's a comment in the chat. Free for us to have installed in the office. Has a large monitor in our waiting room. Oh, so this patient point. Excellent. We're going to have to look into that. Okay.
Yeah, that's a great suggestion, Dr. Colvin. Thank you. We really appreciate your input today.
So to recap, we went through the why. Why at least I went through my why. I know others have discussed it in the past at at meetings. Why this is so important, and several have worked to create this vision document, which also goes through the why. We gave a whole bunch of updates, including how to define chronic pain, which our breakout group agreed with, and we also went through meeting changes, to simplify meetings. Simple is always helpful, wherever possible. Each of the breakout groups had some great key points and things to follow up on. And again, this concept of this video or QR code, and certainly the concept of the start back, as possible best practices. These are future things to explore. And going forward, the executive committee, and we need PCPs, but also having a behavioral health expert on the committee as well. And I think in my experience, virtual meetings go better when there's smaller groups. It's certainly easier to get engagement, and particularly if you have people from throughout the state. So it's exciting what we're going to accomplish together. Appreciate everybody's hard work and input. We know the CQI does create a lot of work, and we know that if participated in this, we have to be motivated by something more than just VBR, because that helps, but it's about doing the right thing, helping our patients, really making a difference in patients' lives. Any other comments from members of our team or anybody else?
No, just thank you everybody for attending and putting up with our technical issues, and look forward to a Zoom invite for our next webinar and not a WebEx invite. So we worked long and hard with WebEx all week, and yet this morning everything had reverted and we've had some struggles. So thank you so much for your patience. We really appreciate it.
And Diane, thank you and the team. I actually think things went pretty well. A few glitches, honestly, I think they were minor, and overall, I think the technically things went well. So thank you to you and the team for planning this. Have a wonderful day,
You're
everybody.
welcome. Bye, everybody. Happy St. Patrick's Day.